It's a shocking realization. 1 in 6 American men will be diagnosed with prostate cancer in his lifetime. On Cancer News Today, we'll tell you why a diagnosis of cancer is not necessarily a death sentence. We'll talk to some of the leading experts in the field and hear the personal stories of those living with this pervasive disease. There are a lot of questions, and we'll help you find the answers. So stay with us. Cancer News Today begins right now. Welcome to Cancer News Today. I'm Pat Lalama. Our focus today is prostate cancer, but first, a few items of interest to cancer patients everywhere. It's a daunting task to try and navigate through the endless maze of treatment options. Leave it to technology to come to the rescue of the cancer patient. A new web app called Cancer Common helps patients, physicians, and researchers share information. Important news for patients with advanced melanoma. Researchers say a new drug is helping extend lives by as much as 4 months. It works by revving up the immune system to attack cancer cells. The average survival for this form of cancer is 6 to 9 months. Given this, 4 more months is a gift. Cancer patients know all too well the debilitating effects of long-term radiation therapy. But what if one dose delivered one time did the trick? In the case of prostate cancer, a Michigan doctor is conducting a promising study on the effectiveness of this one-time treatment. If it works, this may give thousands of prostate cancer patients a better quality of life. Think about this. Nearly 230,000 men will be diagnosed with prostate cancer this year. In the United States, prostate cancer is the most common cancer among men. Dr. Nicholas Vogelzang is chair and medical director of developmental therapeutics at the Comprehensive Cancer Centers of Nevada. Welcome, Dr. Vogelzang. So thrilled that you're going to help guide us through the maze of information. My first question, because we don't talk about it a lot, what is a prostate?
Well, prostate is the organ that makes semen and helps men hold their urine. It's a small gland at the bottom of the bladder, tucked in a very unpleasantly tough place in front of the rectum and at the bottom of the penis. So unfortunately, 2 or 3 of the most important things most men think about, moving their bowels, having urine, and having sex, are all involved with prostate. So
it's a triple whammy.
It's a bad place to be if you get cancer in it. And most men are frightened to death of having dysfunction of any one of those 3. And this disease may cause dysfunction of all 3.
I was personally, as a journalist, astounded at the statistics. Do we have any clue why it is so incredibly pervasive in the United States?
Well, the highest rates in the world are in the Caribbean. The African American population is massively affected by this disease. The lowest rates in the world are in the non-meat-eating vegetarian societies, including some of the Asian societies. North Americans have a very high rate, as do the Northern Europeans. It seems to be related to diet and genetics, and like all things, we don't really have a perfect idea of that.
It says a lot, though, when you just look at that, you know, where it's high, where it's low. It makes you wonder. Now, here, let's talk about here in the United States, who is at risk? Who needs to really think about prostate cancer?
Well, I think all men should have a PSA done sometime between the ages of 40 and 50. Okay. That is a simple blood test. It's called prostate-specific antigen. If your PSA is less than 1, you probably are at 0 risk for having prostate cancer. If your PSA is a little bit over 1 to 2, you're probably still fine. Once you get over 2, your prostate cancer risk starts to climb, And we currently think that anything over 3 puts you at a quite higher risk.
All right, now, you said, let me look at some of the really important notes I've made for this. Young men obviously don't need to be thinking about it. Would it be fair to say, I'm a young guy, I'm virile, everything's cool?
Everything's cool. You don't need to be tested even for prostate cancer until you're 50, unless your father or your brother had prostate cancer. Then it's probably wise to be treated or tested when you're 40 or thereabouts.
You get the news that you have prostate cancer. What is the first thing that needs to be done?
Well, the first thing you need to do is, did my father have this disease? Did my brother have this disease? Because it's a different disease in the families. 35% of all patients with prostate cancer have a family history. So it's much like breast cancer in terms of their genetic segregation. Once the PSA is elevated, you have to go to a urologist. You undergo a biopsy, which is a little tiny needle inserted into the prostate through the rectum. Not so pleasant, but safe and well done and relatively painless. And then that is analyzed for what the cancer or not cancer cells look like. After that, depending upon your age, you're either treated with radiation or surgery to remove the gland. Generally, I prefer surgery and recommend it in most men who don't have serious medical conditions.
Why is that?
It is true that radiation and surgery are similar for about 10 years, but today, out of about the 12 or 15 patients I saw, 3 of them were men who were radiated and then whose cancer grew back in spite of radiation.
It doesn't have to be a death sentence. I mean, what can you tell the patient?
Oh, it's very rarely a death sentence. Out of the 230 patients you mentioned, only about 28,000 will die from the disease.
Of the 230?
Of the 230. And they usually die a decade or more later. We expect that the death rate will continue to drop as we get better at treating surgically and with radiation. The robotic surgery procedure has become very sophisticated, and radiation has gotten very sophisticated.
You know, we were talking earlier, let me just see if I can say this properly. This is a brand new headline just out today that you think is significant. Prostate cancer leaders comment on historic whole genome sequencing for prostate cancer patients. That doesn't mean anything to me,
Right.
Probably not to a lot of people in the audience. What does that mean?
Well, it means that we understand the genetic code of prostate cancer, just like we understand the genetic code of other cancers.
So this is good. This is significant.
It's very good. Now, it will take decades before we can take that code and produce therapies for that. But nonetheless, it's a major advance. And my friends at Dana-Farber and the Broad have done a magnificent job. I knew it would come out soon. I just didn't know when. So it helps us, but not right now.
That's great. Now, a lot of the men that I have discussed this with in the course of my journalistic endeavors on the issue of prostate cancer tell me they had no symptoms.
That's correct.
Explain
there
that to
are
me.
very few symptoms. The gland has very few nerves. The nerves that do run near the gland run to the penis, and they run alongside the prostate, not in the prostate. So only at the very latest stages, when the cancer is very advanced, outside of the prostate do you start having pain and discomfort. Inevitably, the only symptoms might be some difficulty urinating. A patient I saw the other day had decreased seminal fluid or decreased semen volume and slight decreased erections. But those are not necessarily symptoms of prostate cancer. Those occur widely in men as they age. So it's a real challenge to make the diagnosis early.
My last question for now, because we're going to come back to you in a couple of other segments. What about the quality of life? I know it varies depending on the severity, how advanced the cancer is, but what can you tell men out there who may be suffering with this disease about quality of life and what kind of hope we can give them?
Well, I deal with their quality of life as their cancer advances. And believe me, when it advances, the quality of life is bad. So what I tell them is to jump on it now, get rid of it, make certain it never comes back, and take all available therapies now so that you're free of cancer for the next decade or 2 or 3.
Obviously, a diagnosis of prostate cancer is devastating news. But when you're talking about a man's disease, well, the boys would rather talk about anything else. And that can be a big mistake.
I have 4 grandchildren and 1 in the pipe, so to speak. These are the people I never should have met.
Every day spent with his grandchildren is one Bob Each cherishes. 16 years ago, Bob was diagnosed with advanced prostate cancer and told he had a maximum of 3 years to live.
I plunged into deep depression. Deep depression.
Bob has defied the odds, partly with good medical care, and partly, he insists, because he wasn't afraid to talk about it.
Support groups saved my life because I was able to get the information I needed. I was able to meet men in my condition.
Problem is, most men just won't share.
When it comes to cancers or diseases below the belt, men don't like to talk about it.
Dan Zanka's job as Vice President of Communications for the Prostate Cancer Foundation is to get the word out about this pervasive disease. Ironically, 2 years into the job, he was diagnosed himself, stage 4 metastasized prostate cancer.
So when I do a job, I seem to do it well and throw myself into it.
It's just that kind of positive spirit and openness that prompted Dan to begin a blog called My New York Minute, sharing his experiences with men all over the world.
Sharing is very important. It helps reduce the anxiety, knowing you're not the only one out there. Lighten up the load, lighten up the stresses, and you'd be amazed at what talking about it can do.
These days, cancer patients might be tempted to rely on the internet for information. But prostate cancer researcher Dr. Howard Sewell is concerned with accuracy of information online. That's why he encourages participation in a reputable support group.
The individuals will get not only emotional support for dealing with their diagnosis and their treatment and their survivorship, but they also will receive honest and accurate medical information.
Bob Each knows full well men sometimes have to put the tough guy image aside.
We're tough, we're independent, we can take care of the problem ourselves. Well, you can't always do that.
One man who's fearless when it comes to discussing prostate cancer is Paul Trout, journalism and media studies professor at the University of Nevada, Las Vegas. Paul, so happy that you're here to share your story with us. I guess what I want to know is tell me how you found out. Tell me about that day.
Well, everything led up to the results from the biopsy, and it just happened to be on my birthday 2 years ago.
Oh, what luck.
And the telling point, you'll appreciate this, the telling point was I was alone that day, and I was brought back into the urologist's exam room, and the nurse asked me if there was anybody else out in the waiting room. And I went, oops. And so the doctor came in and said, well, you have prostate cancer. And the good news is, the bad news is you have prostate cancer. The good news is in a year we'll be laughing about this because you'll be beyond it. And I don't know, Pat, it's kind of this mixture of growing up with television and soap operas and movies and seeing these stories repeated over and over again, and then it's you. I don't think it really starts to settle in until you get to the car in the parking lot, and then you realize you need to start phoning people. And when you start contacting friends and family who are kind of all waiting to hear the results, and you say, it's positive, I have prostate cancer, that's when it starts to sink in.
Is there a state of shock, a state of denial? Do you get mad? I suppose it's different for everyone, but what happened to you?
I think it is different for everyone. I think given my ancestry and my background, there's a tendency to look at challenges like this. I'm German and Swiss, and so there's this tendency to kind of, okay, grit your teeth, set the sails, what do we need to do here? And I'm going to beat this thing.
What was the treatment for you, and how did it go?
Well, given my age and given what the biopsy showed in terms of what we assumed at the time was an early stage of cancer, I opted for the robotic surgery and had surgery about 2 months later.
Robotic surgery. Now, you're a good doctor, the best there is. What is robotic surgery?
It's surgery under a microscope through tubes that makes the vessels and nerves about 40 times more visible.
That's amazing. And what happened with that surgery? Was it a positive, productive thing? What happened?
Well, in my case, the surgeon discovered complications and something called extraprostatic extension, which meant that the cancer had broken out of the capsule of the prostate and had started to spread to other parts of the body down there. And so he cleaned me out as well as he could, and then it took time for me to heal, because this is major surgery. And then through cancer support groups, I discovered there was this guy in town who was the one to see. And so I went to see Dr. Vogelzang, who said, why aren't you being radiated? We need to get you radiated, and we need to get you on hormone therapy.
And where are you now with all of this?
I was radiated over a year ago, just finished up about 12 months ago, and we're in a 2-year program of hormone therapy, at which point next November we take some tests and we make some decisions at that time.
Doctor, the hormone therapy, what does that mean exactly? What does that do?
It's pretty simple. It's just lowering the male hormone level. It's like making a man postmenopausal.
Well, finally a man has to understand what
Boy, can we relate.
Yeah, it's about time.
Whoa.
And how have you done with that, with the hormone therapy?
The hot flashes are tolerable. The weight gain in strange parts of the body is frustrating. The failure for the body to respond with aggressive exercise is even more frustrating. I'm working out more than I ever have in my life, and with very little visible results, although I feel stronger and feel better.
Did you talk about it? Were you one of the men who said, not me, no talking, or did you just let it out there?
Well, I'm a professor of communication, and I think was drawn to that field and that discipline because it's important to break down barriers in human communication and try to open up channels. And plus, I also consider this part of my therapy. It just helps helping other people. I have colleagues who will contact me across campus who say, "Hey, I understand you're a little further down the road. Guess what?" And what's very useful is to share with them post-operative effects often, because as often doctors and nurses leave that out of the equation when they're getting them prepped and ready for surgery.
What do you think you learned about yourself in this process?
I'm sorry?
What did you learn about yourself? Anything?
Oh boy, that life is precious, that life can be short, to give up sweating some of the details, to hug people every day, to tell them you love them, little things.
I would like to ask you a final question. The issue of death. We have to talk about the issue of death, even though you say there's a lot of promise if you get diagnosed, it's not a death sentence. How do you deal with it? Both of you, I'd like both of you to answer that for me. Doctor, you first.
Well, I, like Paul, was also diagnosed with cancer when I was in my 30s. I shared almost identical experiences that Paul had, although it was a lymphoma. And fortunately, I've been cured. But the sequela, the results of that treatment, are with me today and may lead to complications. So I've had an early and immediate taste of what it's like to face death. And like Paul, of a similar ancestry, namely Dutch, with a little bit of German and Swiss thrown in it, it's like, okay, get on with your life, no crying over spilled milk. And the same hugs, kisses, sharing, and as St. Augustus said, ora et labora, pray and work.
Paul?
It takes a while to figure that out, that answer to that question. But there's a certain liberating quality to having your ticket punched, knowing that the research says about 10 years. Hearing him tell me 10 years, knowing that you're going to beat 10 years and then some. That's basically how I approach the issue.
For me personally, I am really honored to talk to both of you. I've learned so much. I think it's important, as I mentioned before, that women understand this as well. And thank you for your personal story and for your knowledge, and you are in good hands.
I know I am.
Thank you both.
Thank you.
Get this. According to the Prostate Cancer Foundation, walking just 90 minutes a week reduces the progression of the disease by 60%. In fact, it's astounding what diet and exercise can do to thwart the devious cancer cells. Dr. Brian Lewenda is a radiation oncologist, integrative oncologist, and medical acupuncturist. Welcome, Dr. Lewenda. That's a big title you have.
Oh, thank you very much. I'll just stick with radiation oncologist.
It works for us. I am particularly fascinated by the correlation with diet and exercise. I think it's something we can all learn from talking to you. What is an anti-cancer diet?
Well, basically, anti-cancer diet is essentially a healthy diet that's been packaged into many different terms. The heart-healthy diet, the anti-diabetes diet, the anti-inflammatory diet, these are all essentially the same diets. And in fact, if you're following one, you're following the anti-cancer diet and all of them. And so you're decreasing your risk of many different types of diseases and early death. Typically, what this involves is eating a healthy diet. It involves exercising, as you mentioned just a few minutes ago. Exercise decreases your risk of developing many different types of cancers, as well as possibly cancer recurrence and progression. Maintaining a healthy weight, which needs to be done through diet and exercise, as well as many other factors in terms of the types of foods that you take in and preparation of those foods, and stress reduction, smoking cessation. This is all part of the anti-cancer lifestyle.
You know, we hear a lot the term inflammation. Inflammation is supposed to be good, right? But it has its drawbacks as it relates to cancer. Explain.
Sure. Inflammation is a normal physiologic process. It's something that we want to have happen in our body when we have tissue injury, damage, or infection. And when this process is functioning properly, you don't have any types of significant problems. In fact, this is normal health. However, when these processes continue for long periods of time, smoldering low levels of inflammation can release large amounts of proteins within the body, proteins and other molecules that can interact with the tissues, stimulating them to grow, perhaps abnormally. And some of these molecules are very highly reactive molecules. These are called free radicals. And these free radicals can interact with the DNA of your normal cells. When that happens, and the DNA is within the nucleus of the cells, when that happens is you can accumulate sufficient amounts of DNA damage that a cancer cell can ultimately develop over time.
Let me ask you this. What foods contribute to the kind of inflammation we don't want with cancer?
Typically, we are trying to eat a diet that's low in saturated fats. These are the fats that are within dairy products, as well as in red meats. Both of these tend to increase the amount of inflammation and oxidation within our bodies, again, increasing the risk potentially of cancer development. So we do want to limit the amount of dairy and red meats. If you are going to have dairy, usually choose dairy products that are low fat or non-fat. You want to also decrease the amount of simple sugars or simple carbohydrates that are in your diet, and these are such things as the refined flours, sugars, and sweeteners that get rapidly absorbed across the bowel, stimulating a significant increase of glucose within your blood system and insulin, which both of them in themselves can actually stimulate tumor cell growth.
So it's really good to try to stay away from sugar, refined sugars, refined carbs as much as possible. As
much as possible, try to use the complex carbohydrates, which are the grains, particularly the whole grains, vegetables, and fruits. These are foods that have a lot of fiber in them, and the fiber actually decreases the amount of absorption across the bowel wall, slowing this rapid rise in sugar. And these are foods that are considered low glycemic index.
Well, in fact, we have some right here on the table, and maybe we can talk about the importance of some of these things. Now, I noticed you brought canola oil. All right, what's the benefit of canola oil? Well,
canola oil is actually a really good cooking oil. This oil actually has a very high smoking point. And so what happens is certain oils that have low smoking points can actually become carcinogenic or develop various different types of molecules in them that can cause oxidation and inflammation within your body. So canola oil is one of the better ones to use.
And then we have, I'm assuming, whole wheat bread here, which would make a lot better than that enriched white stuff.
That's right. And you have to make sure when you look at the ingredients that it actually says the word whole grain. That's the key word, is whole grain.
Because they trick you a lot, right?
Exactly.
Okay.
Exactly.
And I see bell peppers, really good for you, right?
Mm-hmm.
Antioxidant rich.
Yeah. Most of these foods here that are on the plate, the vegetables and the fruits, the nuts, They contain chemicals, compounds in there that are natural, called phytochemicals, phytonutrients. And these phytonutrients actually have the ability to actually work in a similar fashion as a lot of different types of medications that we use for treating cancers. They can actually decrease the growth rate of tumors by decreasing the stimulation of tumor growth. They can actually work to prevent the formation of blood vessels as they grow to tumors. As you mentioned, antioxidants. The fruits are very high in a large amount of antioxidants. These antioxidants can quench the actual potential for oxidative damage to DNA.
So it's pretty definitive that changing your diet can really make a difference. You know, and this is an incredibly simplistic theory, but it stands to reason to me that if you're walking 90 minutes a week and you're reducing the progression of cancer prostate cancer by 60%, then wouldn't it stand to reason that if you're doing a lot of walking and eating healthfully prior to being diagnosed, it's going to reduce your chance of ever being diagnosed? Is that fair to say?
That's absolutely fair to say. In fact, we believe that 70% of our cancers are related to lifestyle risk factors. 70%, so it's huge. And if we in fact had just a pill, a magic pill that we could take each day that would reduce our risk of developing cancer by 70%, that would be a billion-dollar, trillion-dollar drug.
What have I left out that you would love for our audience to know?
Basically, what you need to make sure that you know is that you want to maintain a heart-healthy diet. Is the #1 most common cause of death in men and women. By maintaining a heart-healthy diet, which is the same diet as the anti-cancer diet, you will, regardless, you're going to decrease your risk of 2 of the most common causes of death. And so following that by eating things that are on this plate, by having a very active physical lifestyle with at least 30 minutes of moderate level activity, 5 days a week is what's typically been recommended, and definitely stop smoking, and watch how you prepare your foods.
Dr. Lawenda, great talking with you.
Very
Thanks
nice
for
talking to you,
very,
too.
very important tools that we need.
Thank you.
Thank you. New drug and treatment protocols are tested all the time in clinical trials. Dr. Vogelzang is back to guide us through our clinical trial of the week. I call clinical trials the laboratories of hope because it's what's new, it's what's happening, it's what so many people are doing to try to help people with cancer. What's new in clinical trials?
Well, this past week we had an article in one of the local papers about this new drug XL184, which is pretty remarkable. It's a pill which causes the bone pain and the x-ray changes on the bone to become much diminished. What we don't know is how long it will benefit patients and how long it will be before they develop side effects. So that's a very encouraging new therapy. On the other hand, we had this Provenge that was developed almost 5 years ago, finally reached FDA clearance, and we are treating now dozens of men with those drugs. That's now off clinical trials and into practice. So there's a continuous change from early clinical trial to practice of medicine.
One of your patients, I read an article with you and him, and he had made a comment because he likes this particular drug. It's helped him tremendously in the quality of life. And he said, I hope unlike all the other ones I've tried, this one continues to work. And I've heard that before. What makes a drug give you so much promise and then boom, it stops working? It's almost like a cruel joke, right?
Well, this goes back to this issue of genetics of the tumor. The tumor is genetically programmed to survive. And we can throw in literally atom bombs at it, and it will, in general, still find a way to survive. That's one reason I'm in favor of surgery, because to get it out, if you can get it all out, it's not going to come back. But once it comes back, it has this innate ability to survive against all odds. I mean, we throw powerful things at it. Now, that doesn't mean we don't extend life. We extend life considerably. In fact, a Nobel Prize was awarded for the very first treatment of prostate cancer in 1940. So we still use that treatment today. That's to lower the testosterone in men. But it doesn't cure the disease very often. So we need to have always new treatments. And as I've told my patients, if we can get X amount of time here and Y amount here and Z amount of time here, pretty soon you're talking about real time. And you keep the cancer at bay long enough and something else comes up, a new drug gets developed.
Someone said to me today that when it comes to clinical trials, a lot of people feel it's their way of giving back. Use me, I'll do anything to help other people not have to go through what I go through. Do you see that in a lot of patients?
I see that all the time. I had a lawyer from Arizona who's driven up, and he was very active outdoors bicycler and active person, and he didn't want to have any treatment. And his PSA was 700, and he went on a new treatment a month ago. His PSA today was 110, and he had no symptoms from the treatment. And so that's a clinical trial. And he, of course, is ecstatic. And I said, good, see, it's benefiting you, and it will benefit future patients.
If people want to get involved in clinical trials, what do they do? How do they know which are the right ones? Who do they call?
Well, the clinical trial is not for everyone. Only about 10% of all patients can go on them.
Why?
And because they have other problems. They might have heart problems. They might have had a stroke. They might have had another cancer. They may have a hepatitis or some such. There's a variety of things that exclude them. In my practice, probably 25 or 30% of patients go on clinical trials, but that still leaves a large number who cannot. The guy today who I wanted to have go on a clinical trial, he can't. He's got an early problem with his bone marrow. He has a severe type of anemia and just can't go on. So it's not for everyone, but you should certainly ask your oncologist about them. And if your oncologist says he doesn't have a clinical trial, you should go to clinicaltrials.gov and look it up. There's a list of all clinical trials in the United States listed by our federal government.
How does a person know they're dealing with reputable people? I mean, I think there's a lot of voodoo out there in terms of information. How does someone know who to listen to, where they're getting the best, most accurate information?
Well, my career has taken me from University of Minnesota to University of Chicago to the Nevada Cancer Institute to this institution. And I've dedicated my life to cancer research and cancer treatments. I can't speak for most other docs. I think the commitment to do cancer research begins at an early age, usually in your training period. So what you look for is someone who's been a faculty member at a university, who has published papers or has at least had their name on papers, and someone who is actively involved in the disease of interest, be it breast cancer, leukemia, prostate cancer. The world of cancer is very different. There's 250 different cancers at least. So you can't be an expert in everything.
This is my final question. What made you decide to make your life a life of helping people with this pervasive disease?
Well, I think my father, who wanted to go to medical school, ended up becoming a preacher.
Okay.
And my mother, who was a teacher, together with them and their family, encouraged all of us to go into the helping and healing professions.
I cannot tell you how honored we are to be able to talk to someone of your stature in this field and helping us, understand it, putting it in terms that even I can go, okay, yeah, I get that. And it helps not just the men, but the women in their lives too.
Thank you. My
Thanks
pleasure.
so much for being with us.
You're welcome.
We're grateful to all of our guests for sharing critical information. Knowledge is invaluable, as is the sharing of personal, intimate stories. Diagnosed or not, every single American is touched by cancer. I'm Pat Lalama.
For more information on Cancer News Today, or for additional resources, visit our website, cancernewstoday.tv.